Hello, everyone. Welcome to our latest seminar. We're really excited to introduce a new data partner to bring into the Dewey data ecosystem, which is Serif Health. We really love these seminars because it allows us to kind of dive deep into these new partners, kind of give some background about who they are, kind of what data sets they are building, and then a little bit more information about how they collect this data and some of the research use cases as well. Before we jump in, we want to just get some participation going because we do love if these are participatory. So we asked a quick question here just to kind of get a sense of, for the people on the call, are you kind of working with healthcare data or interested in some, research that might benefit from healthcare transparency data? It's definitely okay if you're not. I know a lot of people are here just to kind of learn more about the next, partner that we've added to the Dewey ecosystem, but we're certainly interested in hearing your thoughts. So we'll keep this pull up for a couple seconds. As the answers trickle in, I will say that we do love your questions throughout the presentation. So please don't hesitate to use the Q&A feature or the chat feature. Throughout the presentation, I'll kind of be moderating, and so if you have a question that's specific to the slide that we're on, feel free to ask it so that we can answer live and just keep the flow going, or we'll answer any questions that happen at the end. So we can go ahead and wait for a second as these polls wrap up. Perfect. All right. Half and half. So we see half are considering it and half are here to learn more. All right, let's keep moving. Yeah, so like I said, please use the Q&A feature in the chat. The Serif Health data is live, and so if you want to follow along, you can start to actually sample the data as well, going to app.deweydata.io. I think most people here already have their accounts, and so if you are, a subscribed user, you'll actually be able to start to download the data as well. But if you're not, you can also download some of the samples data. And this session will be recorded, and so we will be following up with anyone who registered with a link to the recording. We like to share this because a lot of people ask and you don't have to scramble to take notes. We will definitely share the slides and the recording after. And with that, we'll talk a little bit about what we're going to work through. So we're going to introduce the Serif team quickly. They're going to walk through some of the methodology of how their data is collected. And then we're going to turn it over to Taylor, who's actually kind of the lead researcher at Dewey, and she's going to talk through why we're excited about this data set. We've got a chance to kind of get our hands in the data and dive in, and there's a lot of really cool research use cases and applications, which she'll cover towards the end. And like I said, one more time, questions are very welcome, so feel free to ask along the way. So with that, I think I will turn it over to Whitney and Blake from the Serif Health team, and they will go ahead and kick us off.
Awesome. Really great to be here and meet you all. So Blake and I will sort of be tag teaming here for Serif Health. My name is Whitney Adair, and I head up growth, especially working with some of the folks in benefits and employers and researchers actively trying to understand rising healthcare costs. So that's a little bit about me, and I'll hand it over to Blake.
Yeah, hey everyone. Really nice to be chatting with you. My name is Blake. I am the head of our customer team. So I work with our current customers every day in the price transparency data. Whether it's researchers, hospitals, payers, employers, all different types of customers that can really get a lot of use out of this data. So I'm excited to chat a little bit more about what we do, the data we have, and then Whitney's going to present some research or use cases that I think will be really applicable to you all. Awesome. Well, to go ahead and get started, for those of you that are not familiar, here at Serif Health, we are, the leader in price transparency data analytics. And for those of you that don't know about price transparency data, there was a federal mandate passed in the early 2020s that required all health insurers, so payers, as well as hospitals, to disclose their negotiated rates across all codes or services that they perform. This was, a pretty big deal because historically it has really been a black box, in the industry about understanding what, are providers getting reimbursed for certain services? What are the costs of different services? So this was a really big mandate. Now, this data posted by payers and hospitals at its core is very, very large and also very, very messy. So that's where we come in at Serif Health. We've been ingesting the price transparency data posted by both entities for the past several years. We have some very, very specific ways that we clean the data, validate the data, ensure that the rates that we are presenting in any scenario are validated rates that are being billed by the right providers. So that's really where we come in as a company. We are taking this raw data, cleaning it into its purest form, and then allowing folks like, researchers, hospitals, payers, everyone across the ecosystem to use it to understand pricing trends. So, a little bit about our kind of data and data sources. We collect data from over 240 payers every single month. That's across 600 networks. So a payer might have, multiple networks, a PPO, HMO, exchange. And we have data from over 5,000 hospitals that post this data as well. So, very extensive data quality. I'll talk a little bit about what's available in the Dewey platform. But again, we collect this data, update it monthly. You can see kind of in this graphic here the types of rates that are being posted, that are being collected. So the biggest thing is the allowed amounts. So if you're not familiar with what an allowed amount is, that's a negotiated rate between a payer and a provider of what the provider is going to be reimbursed for a service. So, the focus in the Dewey platform is the payer posted price transparency data. It's the richest data set. It has, professional fees as well as institutional fees, which would be the difference between a cost, for a doctor performing the service versus the cost of actually using the facility. So we break it down to a very granular level. And we have all that, available in the platform. Now, what I will say is the payer posted data is focused on the commercial and exchange lines of business. So in the Dewey platform, you're going to see those commercial and exchange negotiated rates. You're not necessarily going to see Medicaid, Medicare Advantage, but those are kind of questions we can answer in the future, and there are various ways that we could collect that information. So this is, kind of a little bit more about our data. What's available live right now in Dewey is what we call the BUCA networks. So BUCA is an acronym for Blue Cross Blue Shield, United, Cigna, Aetna. Those are the four biggest commercial payers by far in the United States. So all those major payers, the data will be there. I think we have, more than 300 or so billing codes loaded up into the platform. So it really allows you to do a lot of very interesting price transparency analytics. So that's a little bit more about our data and what we collect. Moving on, I want to talk just a little bit more about our data methodology. Probably, very interesting to a lot of researchers here that want to know and learn more. As mentioned, we really have a three-step process of how we clean and validate the data, which is really, really important because the raw files are very large and often very messy. So we have a pipeline set up where we automate the ingestion and processing of the data. So the payers will post data monthly. We have an automated flag that actually picks up and downloads this data. It is trillions of records. It is terabytes and terabytes of data. So they're very, very large. We found a way to optimize storage, costs and compute costs to make sure we can collect it in an efficient manner. Step two and step three of this process is really where, we differentiate. So we get a lot of questions like, hey, this data is publicly available. Yes, it is, but it takes the right cleaning and analysis to make sure you have the right insights. So we've been collecting historical data. We benchmark the data against historicals to make sure all the rates make sense. We eliminate what's called ghost rates. So think of a ghost rate as a rate, let's say, for a dermatologist that has a rate for a knee surgery code. We know in the real world a dermatologist is never going to perform a knee surgery. So that, in our case, is going to be an invalid record that we'll actually remove from the raw data. For some payers, we remove upwards of 80% of the data. that's coming through. And then obviously we have a very robust accuracy feedback loop from all of our customers. And then a few more things that you'll see in the data are things that we do to enrich the data. So we enrich the data by adding Medicare baselines. So typically, a lot of providers want to see their rates as a percentage of traditional Medicare. So a commercial rate might be 200, 300% of a traditional Medicare rate. We add all those references in so that you can compare those rates as well. We add provider names, we add locations. None of that is available in the raw data. We also normalize the data. So we've noticed that some payers use custom codes to post their rates. And we actually know that they crosswalk to, a relevant set of traditional codes that you might be used to seeing. So we do that crosswalk to make sure you're getting a full, complete, accurate picture. And then, yeah, we normalize across markets. So this is, kind of our bread and butter of what we do. We are at its core a data company. We're processing trillions of records and making them actionable. And we're really excited to be partnering with Dewey to have our cleaned and validated data available on the platform.
Yeah, and I did just want to take a beat. If you all have any questions as we go along, feel free to pop them in the chat, and we're happy to pause and answer questions, even about different kinds of billing codes, that sort of thing.
Yeah, I think I saw one question in which I'll read in a second, but I'll comment. I think this is like such a key slide here around the methodology and how much work goes into collecting this data. Because I think it's always tempting for researchers who know that there's like publicly available data just to consider, oh, I can get it from the source and it's going to be easy to use. And I think we've seen time and time again how hard that can really be. And I know in this data, especially the raw data that you're ingesting is, like you said, terabytes and trillions of records. It's such so much extra kind of like unnecessary bulk data to even start the process, much less the cleaning, the normalization, pulling out those ghost records, etc. This is one of the examples where it's that processing is just critical. And then in order to actually receive, up to date data that you can see every month, you'd have to do that same process over and over and over again. So definitely is one of these opportunities where, the methodology and what you're providing on top of this data is like pretty incredible for, how much work goes into creating this output that you guys have done. So it's been really cool to see, and I'm glad we went a little bit deeper into some of that methodology.
Yeah. And I think it's hard to overstate the amount of technical infrastructure that's been invested in here, in terms of data science and data engineering to make sure that everything flows really seamlessly for for our partners and customers. Um,
Yeah.
and the other thing, Blake, that I think is worth highlighting on the data methodology and sort of um, kind of the bonus of working with Serif is our team becomes a resource as you're thinking through research questions. So recently we had a research partner reach out to us and ask about different kinds of uh, rate structures in the files. And we were able to help show them that um, we could, they could compare some apples to apples that they didn't think they were able to. And if they discarded, it might actually weaken their analysis. So, Blake, I think you actually answered that one recently. So, I just thought that was a great example of how we're able to partner.
Yeah.
Yeah, I will chime in with two questions that came through. One, the quick one, I think we touched on, but how far back does the data go in Dewey? And can you remind us like when the historical coverage starts?
Yeah, so we have been collecting this data since 2020, late 2023. I believe we are refreshing the data in Dewey with the latest kind of available rates. But if there's any historical projects that, you want to see historical rates over time, happy to, partner and make sure everyone that gets the data that they need there.
Sounds good. And there's one question, it's a little detailed, so I'll try to summarize it as best I can. I
Yeah.
don't know if you can see this in the chat, but I'll maybe start with the second question around like drug spending. Oops, it just moved. It says the data currently provided in Dewey is only provides the per unit drug reimbursement rate and does not include the dosage associated with visits. Any thoughts in terms of like the specificity in terms of what's actually provided, relative to what maybe a patient thinks about or receives?
Yeah, happy to answer this and go in. That's a great question. So a HCPCS code is going to be around again, yeah, that, like the question mentions that drug administration. Um, that kind of that level of detail is what is required to be posted at this time by the providers because they are getting reimbursed based on the administration of the drug. Now, on the manufacturer side, this is actually not data that's required to be posted just yet. Now, there are a lot of updates from CMS that this data is coming pretty imminently. So I would say in the next year or so, we should have a ton of updates on um, the actual manufacturer and PBM side of things. So that's, something that's to come on the actual manufacturer side of things. And then another question around per unit drug reimbursement. Associated with each patient visit. So every rate that you're going to see in the data is going to be that per unit allowed amount. So don't think of it as a claim or don't think of it as an actual patient visit or event. Think of it as the per unit allowed amount, what the contracted rate is for each unit of that code. So that's kind of a good way to think about the data here. It's the contracted data rather than a listing of visits and the number of units per visit.
And for some of those J codes and drug codes, the dosage can vary by the individual patient. So it allows you to really look at the unit cost and then flex it up. I in my work with with employers and benefits advisors, um, sometimes it is good to have that context because sometimes a like $50 unit rate is actually something you need to times by 600 because the actual dose is like 600 milligrams or something. So that's just a good caveat with that kind of analysis.
Yeah, but those are great questions, and goes to show you all have already been diving into the data, which is very exciting.
So nice. I think let's keep moving and I'll let you know if any more come through. And then obviously if we don't get to any of the more detailed questions, we can always follow up afterwards as well.
Perfect. Yeah, I want to make I'll spend just a little bit of time on this slide. There are, a couple other kind of players in the market that are in the price transparency space. This is just a comparison of, some of the filtering we do versus some of the others that, may not have the most enhanced level of data enrichment, access, analytics platform. We've really invested a lot of being the experts in price transparency data. Our team is mostly data engineers, data scientists that are into the weeds of data every single day. So we have invested a ton in the data enrichment and validity here. And also on the data access side of things, I think something that's really unique about us is we really want to partner with researchers. We really want to partner with folks in this space, whereas other groups or other companies might employ their own researchers or publish their own papers or articles, or maybe have contractors that do it for them. We actually want to be the ones that are providing the validated, enriched data to researchers to allow them to, do any work or project that they're interested in. So that's why, the partnership with Dewey was so exciting for us. And we can be that data provider. So that's kind of just overall the summary. We do have outside of the Dewey platform, we have our own analytics platform that, functions very similar, uses the same underlying data. So that's how a lot of our customers choose to interact with the data. But specific for this researcher use case, we're super excited about the partnership here and want to make sure that everyone has access to the data that they need. So I think that's just a little summary about, our methodology, our stance versus some of the others in the space. Whitney, anything you'd like to add there?
No, no, I think you hit on all of it. I'd say that we try to be really flexible and we care that this data gets out and is used well in the world. And so, yeah, that I just to reiterate, that's why we were really excited to work with Dewey.
Awesome. Well, a little bit more about our customers. This data is, um, as you can probably imagine, applicable to a wide variety of use cases. Um, you know, think about the reimbursement rate between a provider and an insurance company or a payer is going to be very important to a provider, to a payer. It's eventually going to trickle down to end patients. It's going to be important to consulting firms, investment firms that do research in the space. It really unlocks an entire set of, competitive analysis in a given market. A good kind of parallel that we always think of is, in, let's say, the consumer packaged goods space, the fact that Amazon is able to display, publicly the prices for a given item, um, in a certain region, and it's clear to the end customer, it's clear to competitors what pricing is available on Amazon versus Best Buy versus, the shop down the street. This is kind of the unlock of competitive analysis that this price transparency data enables for every stakeholder that's involved. And our overall philosophy is that more transparency introduces more competition, which ultimately decreases, prices overall. That's our kind of, overall mission in the space in general is, to contain healthcare costs. And we think price transparency, and that's kind of the reason behind the mandate is playing a big part in that. So we work with a lot of different groups across. We work with provider groups that are interested in understanding kind of where do they stand in the market. We work with consulting investment firms that are working for their end clients or doing different analysis on markets they operate in, or maybe, exciting companies they want to invest in. And then most importantly, we work with a lot of researchers and journalists. Our data has been referenced in a variety of published articles. We've been, included in a wide variety of press releases. And, I think, it's something that's really exciting to us when we can, say that we cleaned and validated data that's being, used in the public eye for public good. So something we're super excited about. Obviously, that's going to be the use case for most folks here. So that's just a little bit more about the different types of customers we work with here at Serif.
Yeah. And just to highlight a couple of the investigative journalism uh, partnerships we've had, we were recently featured in a Washington Post investigation on pricing in hospitals. And also, I believe it was last year, worked with the International Consortium of investigative journalists around a piece on pricing for Keytruda, which is a very expensive cancer treatment. So, just some illustrative areas that the data has been used and cited. Going a little bit deeper on use cases, this is where I hope we can start to generate some ideas. So if you're thinking about writing a piece using healthcare price transparency data, maybe these can be some good places to generate some ideas. Um, so there's a couple of different areas that we see the data being used for investigative research or just research in general, especially within benefits and employer space, price variation and site of care economics. Employers are actively trying to figure out how to think about site of care for infusion therapies and even getting elective surgeries or surgeries that are easier to shop around ahead of time. Price variation by site of care matters. We'll see that with ambulatory surgical centers versus an outpatient hospital department. Um, for surgery. Also for infusion therapies, we'll see that if people go to a clinic or elect for at-home infusion therapy, it can be a fraction of the cost with facility fees um, of going to an acute care hospital to get the same treatment. And by that, I mean it can be 10 times more expensive. So that's just anecdotal, but I think that there's interesting things there to think about in terms of therapies, procedures, and price variation just based on where the care is delivered. Uh, then also thinking through market structure and payer provider dynamics, because the data is nationwide and very comprehensive in terms of who's included, the payer data, why it's the place we often recommend people start is because it includes everybody who has an NPI in the United States and bills through commercial insurance. So that's a pretty wide net in terms of what kinds of providers you can see. It allows it allows looking at competition within markets. It allows us to think about market structure of service lines in different markets and within different institutions. And also, and I think we've seen some interest in this, looking at market concentration and provider bargaining power. So where are we seeing prices higher? It might not surprise folks to hear that large health systems and those with big market share may have higher prices in a specific market. But those are all good areas for deeper research. And then policy and market impact, looking at how price transparency influences healthcare markets, what has happened over time once this data has become available, and how has that changed competitive dynamics? And is it fulfilling the promise of what we thought price transparency was going to do when it was first instituted? So those are all questions I would leave up to this crowd. But hopefully, like I said, these are good ideas and areas. We also wanted to dive into a few case studies. So I have 3 case studies to walk through. Assuming that we have time, Evan, feel free to give me a warning if we're going a little too close to time. And you will all get these slides as a follow-up. But some of these are research that we needed to do internally just to understand, and some of them are examples that we've partnered with customers and researchers. So, for example, this was some research that we did for our State of the Data report last year because we wanted to really take a step back look at price transparency and what could be gleaned from the information that was available. And so for this, we were looking at negotiated rates for, I believe this was a hip and knee replacement, DRG 470. And the question was, were there differences between different cities in terms of how prices changed over time? And the takeaway was actually, yes, there were differences. Um, and if we look at Blue Cross Blue Shield of Texas negotiated rates, I believe the top lines that are like orange and yellow are for Dallas, and we were able to split that out inpatient and outpatient, versus the lines at the bottom of the screen, which are green and blue, are for Austin. And you can see that there is a big price differential even between major cities in Texas. And also how the trend lines look within those metros, which might suggest if anyone was up for looking at a broader view of this, that price trends are locally driven potentially and have unique market dynamics within each area that these hospitals and centers are operating. But we did see an overall 24% increase between January 2023 and January 2025 for this DRG, which is also of note because that's higher than inflation. It's higher than we've seen healthcare prices rise just generally. And if we move on, this is an example of looking at service lines. So there was a question here of, is there a difference between service lines and how the spread pricing looks? So that's, the minimum pricing versus I think we went up to the 90th percentile here. And I know that this was on, I think it was just on Aetna, Blake, if I remember right, when this research was being done. So this was also just on Aetna, but looking at this, it was interesting to see that overall, if we're looking at inpatient, the story was different than for outpatient. So the negotiated rate percent of Medicare for inpatient service lines were fairly similar with some outliers. For example, if you look over here, newborns with conditions originating in the perinatal period had a different pattern than maybe some of the other service lines. But if we looked at negotiated rates, percent of Medicare by outpatient, we saw that there were more marked differences in the spread. For example, anesthesia pricing had a a broader range of prices that could be listed. Um, these also, anesthesia practices are often contracted by hospitals or ambulatory surgical centers. So uh, it's interesting to know both the business model and think about how that could be influencing some of the prices here. So that was a key takeaway. And also, I think for this group, it's also just key to know that percent of Medicare, why we keep referring back to that is one, because a lot of folks who are negotiating healthcare prices use percent of Medicare, but also because it allows us to normalize the data to correct for data set asymmetries. So say, especially in the case of service lines, say we're missing some code sets from a specific payer that might not include as many HCPCS codes or over indexes on revenue codes, et cetera. And by normalizing to percent of Medicare, we can still compare apples to apples instead of having the data skewed in a certain way. So that's something that we would just put out there if you haven't worked with this data before, that Medicare benchmarking is a key piece that we often use. And then finally, this is kind of a different use case for the data. There's been rapid growth in behavioral health MSOs. So think of, these virtual care companies who are offering therapy to and therapeutic interventions to a broader range of people that's more accessible because it's now telehealth and it's a lot easier to access. And if we think about today versus 5 or 10 years ago, there's been increased utilization of that. Um, and so what we can do a little bit outside of pricing, but with the pricing data, is thinking about provider network analytics. Because every provider has prices tied to these different commercial insurers, then we can look at how groups grow, what overlap they have in NPIs and individual providers, um, how churn happens, how the market is changing. And so this is sort of a snapshot in a specific sector of the healthcare market, but this allows for broad opportunities. If you're interested in provider networks overall, you might not think of price transparency data as a place to potentially utilize for that kind of analysis, but is very useful because of how comprehensive it is. Um, and for example, one of the insights that we saw by tracking data this way in this behavioral health space is that during the analysis period, which was 10 months, we saw a 43% increase in active providers across the markets we looked at, which is just kind of eye-popping thinking about that in the span of 10 months. And also that there were significant overlaps in areas that two groups that we looked at, large virtual behavioral health MSOs, had up to 17% overlap in their provider networks, which does indicate that providers are not just providing care for one specific clinic or one specific um, group universally. So that was our case studies for now, and I'll just pause to see what kind of questions we have, or Evan, if there's any other wrap up you'd like to do.
No, this is really cool to kind of dive in. I want to make sure we give Taylor some time, excuse me, to jump
Yeah.
into some of the use cases that we've seen on the Dewey side, because I think it's a testament to how excited we were about this partnership. So, unless there's anything else you wanted to quickly touch on, and maybe we can switch it over to Taylor.
for it.
Awesome. Well, as she gets up set up, I'll just one time want to thank Whitney and Blake for joining. Like I said, this has been a really great partnership already, and we're super excited about this data. Taylor's going to jump in a little bit more about the specifics of the data, but I would just say from a partnerships point of view, I really like the messaging you said around just wanting to be the conduit to opening up this data to more and more people, either researchers or your other commercial clients. And I think your like willingness to try to open up and reach as many people with this data is awesome, and I think why we're really one of the reasons we're really excited about this partnership. And I think that also kind of is passed through to our users, where if you do have specific questions as you start to play around with this data, the Serif Health team has been really leaned in to kind of help make sure we get those questions answered. And so feel free to use that discussions portal that's in the Dewey platform. If you do have detailed questions, might be harder to cover in a session like this, but we can certainly loop in the team as needed to get your other questions answered. And with that, I'll introduce Taylor Butler, who's our research lead. She was very excited to dive and get her hands on this data, and so she'll be kind of talking through some of the use cases that she's seen already.
Thanks. Yeah, and I really appreciated seeing those case studies. Those are great examples. But yeah, as the Dewey team here knows, I've been very excited about this data, just because I think that's such a untapped research area. Um, and thanks to these transparency and coverage regulations that were passed a few years ago, this really is just a novel research area because it's a novel data source itself. Um, and as you guys touched on a little bit as well, transparency doesn't mean usability. And so even just diving into the research a little bit myself and seeing how the research community has agreed that these raw data files that are being released is a good thing, but they're not really usable for research as they are. One of the major problems being those ghost rates. And so researchers so far that have been trying to use this data have really been limited to either really small case studies and samples, whether looking at just one service code or one small region, and face pretty consistent data quality issues. So I was really excited to be able to dive into this data and see how easy and usable it is. So I'm just going to take a couple of minutes to share a few data visualizations as I sort of did some exploratory analyses into the different types of questions that can be answered with this data. But yeah, I also just want to point out that there are some revisions being made to the amendments to sort of require these negotiated rates and raw files to be more usable. And I love that the Department of Labor and Treasury's proposed amendments actually cite Serif Health and your cleaning methodology as what to mimic going forward. So while that might take a couple of years to be implemented, this data is ready to use right now. So you guys sort of already highlighted a few of the major research questions. So I'll just quickly share a few of the data visualizations that I had some fun making, looking at different types of research questions that can be answered here. And this is just looking at a really small subset of the data. So I just looked at the blue card data set in California alone. And with almost 300 billing codes, about 8 million rates, 85,000 contracts. That's really robust data to be able to look at very specific specialty level analyses, taxonomy, and looking at maybe which specialties are underrepresented or overrepresented in a specific network. The granularity and range of the prices themselves, from cent differences for drugs and blood draws all the way into imaging and inpatient stays. You can look at how price variation differs across types of care. I also thought this was really interesting that you can sort of look at sort of contracting strategies themselves. So looking at how Clinicians are pretty much mostly on a fee schedule, whereas institutional hospitals have a much more mixed contracting strategy. And again, this is just a small sample of the California data. It's very easy to join this to a simple zip code with your hospital level data. So you can easily look at how the cost of a single service, like a chest x-ray or a routine office visit, varies across the state. And then similar to what you were mentioning is seeing sort of the differences in rate across providers. So for the same procedure in the same network, we're seeing, even in California, sort of an average of the top providers being paid 2 times more the lower providers across a number of different services. Again, those built-in benchmarks make it really easy as well to do those types of analyses. So how does these commercial rates compare to Medicare? And seeing if that rate varies by service type. Looking at how big health systems maybe compare to some of the smaller ones. And I'll quickly glance through. I did sort of a full deep dive. If anyone wants to read this data exploration, you can find the whole article that also dives into some of the policy history here, and includes some reference work to some of those smaller case studies that have explored this space before. Again, you can explore the data on Dewey. And I'm really excited to hear from our researchers and see what they do with it, because again, not only is it a new data source, but I think there's such potential for impact. And I really appreciate you guys sharing that is your goal, is to get this data in the hands of the researchers. And I think that's what I'm equally excited about as well.
Awesome. Well, thank you, Taylor. And Blake, Whitney, again, thank you for joining. I think we're close to time here, so we'll probably wrap it up unless any last questions come through. But Kelly posted in the chat, any more detailed questions are perfect to post in the discussions forum in the Dewey portal. Like I'd already mentioned, the Serif team is very leaned in to help us kind of get your questions answered, especially because we are introducing, a newer data set to the space that I think we're really interested to see some of the research applications. And so we definitely want to help those early researchers through their questions as they start to play around with the data. And we can't really wait to see the papers that come from this. And so once again, thanks to the Serif team. Taylor, thank you for presenting some of your early findings, and we'll go ahead and wrap it there. But everyone, hope they have a good rest of your day.
Thanks, everybody.
Thanks again.